خیلی ممنون که امروز تشریف آوردین. Thank you for coming. Merci. Thank you, Pam, for allowing me to join you and give a lecture about joint replacement surgery. So, first of all, how many American speaking here? Everybody's American speaking. How many Persian only? How many know Persian?
Persian is here.
No, you don't speak. I know it doesn't speak Farsi.
English is the first.
Yeah. So, and two. Okay. So, I'm going to speak English and in mix in Farsi. That way, sometimes, so everybody can understand the vocabulary, because the vocabulary and the language is a little bit difficult to understand in orthopedic surgery. So, we're going to start. I'm going to give you a background about myself, just very quickly, briefly. I did my college education in California. After California, I left to Midwest, Ohio State University for 4 years of medical schooling. After Ohio State University, I did 6 years of surgery training in New York. And then I came back to California and did 1 more year of super specialty training in joint replacement surgery. So essentially, it took about 15 years to finish the schooling. And then after that, I've been in practice for almost 14 years now. So we've been doing this 14 years. Right now, I am basically at Providence Health System at Holy Cross. I've been there for almost 14 years. I started there. And at the time that I started doing my practice, it was the era of the change in orthopedic surgery, in total joint replacement operation. The total joint replacement surgery is basically an operation that is designed to get rid of the bad joints and put a mechanical joints in place, so the people who have severe arthritis and they cannot walk, they can walk again without pain, so they can enjoy their life. So the time that I started doing the practicing, it was the time that we started inventing how to do this operation with the smallest amount of incision, with a small amount of scarring, so the patient can recuperate faster, go back to life without any delay in time. Because previously, the operation was extensive. The scars was about at least 12 inches. The patient would stay in the hospital about 10 to 12 days before they go home, and it would take him at least 4 to 6 months to recuperate. Once we started doing minimal invasive operation, which was the exact time when I was in my training, and with my mentor, we were actually in the operating room designing the instruments, how to do this operation with a 3-inch incision, so the patient can go home in 2 days instead of 12 days, and getting back to recovery and recuperating so they can go back to work and enjoy their life as little as 4 weeks. I had patients that I did this operation, and after 4 weeks, they were on the ski slopes, skiing already. So it was a very certain time in the era of the joint replacement operation that we were able to improve the techniques that the people can really get back to their life as quickly as possible. So we're going to start talking about what is arthritis and what is it that arthritis do to people, and what is the change in the anatomy that causes the pain, the things that we can do to improve it, and if for some reason the things that we can do to improve it doesn't work, then what kind of a surgery is it that we can do to fix the problem. So the way that basically orthopedic surgery works is that we are here to basically improve the patient's lifestyle, so they can go back to normal sports, normal activities, so they can enjoy their life. This is a picture of a pelvis area. This is the hip joint. Arthritis, when we talk about arthritis, that means the change in the cartilage. So if the cartilage, which is the cushion between the socket and the ball, is worn out and it gets destroyed, then you're going to start getting bone-to-bone contact. And that's when the bone starts grinding, and that's when the pain starts bothering the patient. This is a picture of a knee joint. This is how the progression of the arthritis starts in the knee joint. The knee is a pivot joint You have a top bone, bottom bone, and ligaments in the middle. The arthritis starts setting in. It gets progressively worsened, starts affecting the areas where we put our pressure on it in the inner and outer side. And ultimately, it becomes really bad, and you start getting bone-on-bone contact. And that's how the pain starts bothering the patient. We have about 38 to 40 million people affected in arthritis. This statistic is going to exponentially go higher because we are at the era of the baby boomers. So the patients' populations are getting older and older. So therefore, we are going to see a lot more arthritis as we go to the 2020s and 2030s. And that's where orthopedic surgery has become the focus point in healthcare. As a matter of fact, the Obamacare and all the changes in medicine, the number one area of topic of discussion is orthopedic surgery, because this is the most costly operation that the United States is facing within the next 20 years, because the age of the patients and the baby boomers is going up. So what are the most common forms of arthritis that we deal with? We have osteoarthritis, we have rheumatoid arthritis, and we have trauma-related arthritis. Osteoarthritis is when we have the cartilage wears out and the bone starts rubbing. Rheumatoid arthritis is an inflammatory disease. That means your body starts developing some cells and molecules that attacks the cartilage and basically destroys your cartilage. It can affect a lot of the joints in your body. Post-traumatic arthritis are people who have had sports injury or accidents or some sort of a traumatic fall, and the bone breaks, or you had an operation and that manipulates the cartilage, and with time that cartilage, because of that insult, starts getting arthritis down the road. The osteoarthritis is the most common form of arthritis that we deal with in the United States. Rheumatoid arthritis is about 10 to 15%. The post-traumatic arthritis is about 8 to 10%. About 80% is osteoarthritis that most people are complaining about. So what is osteoarthritis? Like the tire of your car that you have when you drive it. Every tire has a longevity of 40,000 miles. The human body also has the same thing. So the cartilage in your body can only last probably up to 55 to 60 years of age. That's average norm. Some people can last up to 75 to 80s. Some people can last up to 45 or 50s. But the average lifespan of a cartilage is about 60s to 65 years. After that, it gets eroded, it gets worn out. Like the car that you have to do a tire change, it becomes a time that you may have to do a joint replacement and change your joints. So this is the X-ray of a patient with a bad arthritis. Normally, when you have a good space, this bone and this bone is separated by about 5 millimeters of the space. If you get bad arthritis, you get bone-on-bone contact, and that's what the cause of the osteoarthritis is called. It could be moderate to severe, it could be very severe, it could be mildly severe, but ultimately what it does, it causes loss of mobility, loss of range of motion, physical disability, and basically as a result of the pain, patient's lifestyle starts altering. So what is the job of an orthopedic doctor? The orthopedic doctor is supposed to come with some sort of a solution and a plan so we can start treat the patient, so we can make him free of pain, make him increase in range of motion, so we can improve the lifestyle and the quality. So at that point, we talk about the patient to manage the arthritis, give him some medication for pain medication, for anti-inflammatory purposes, and basically a balancing act between activity and rest. Rehabilitation, physical therapy, modalities for pain like anti-inflammatories, ibuprofen, Motrin, Aleve, all that stuff can really be beneficial to the patient. Educational programs such as weight loss, getting rid of obesity and all that will be very helpful, because the less the body has body weight, the less painful the joint is going to be. So majority of the things that we can propose is analgesics, NSAIDs, we call it non-steroidal anti-inflammatory medication like ibuprofen, Motrin, Aleve. or it could be a walking aid like a knee brace. We can give him a steroid injection. Sometimes if the medication doesn't work, we have to give him a little cortisone injection inside the joint to reduce the inflammation. And ultimately, after that, we have the gel shots. We call it hyaluronic acids. It's known to the Persian population as the Taj Khurus, okay? And ultimately, we can also do that too, and to see if that's going to help with the pain and the symptoms. The other things that can possibly be beneficial, and the patients can buy that in a market, is glucosamine chondroitin. You can buy that from the Costco or any pharmacies. Vitamin E can be beneficial, and those can lubricate the joints. And arthroscopic surgery is basically a camera surgery, which we put a camera inside the knee joint, and we can do some cleaning up. But we cannot reverse the arthritis. It just reduces the tears or the inflammation that potentially can help the patient. But once we've done all this and that doesn't work, then ultimately we need to talk about what else can we do to help the patient. And that's when the orthopedic surgery comes into place. So the things that we talk about with the patient is basically what we're going to do, how we're going to treat them. 95% of patients have very excellent results after the operation. The pain becomes very less, and they're very happy with their lifestyle. The most common joint replacement surgery in the United States is a hip replacement and knee replacement. About 600,000 a year it is done in the United States. So what is total hip replacement surgery? Total hip replacement surgery is when you have a bad ball and a bad socket, we have to go and replace it. And the way we have to replace it is that we need to get rid of this bad ball. We have to open a canal in the bone, in the thigh bone, and we have to insert a shaft, which is called a femoral stem, and it has a cobalt chrome or oxinium ball on the top that basically makes the ball of the hip joint. And then we have to resurface the socket, and we have to put a metal shell and a special plastic, and that becomes the socket. And ultimately, this is the picture of it. So we have replaced the shell, we have replaced the stem, and that becomes the new ball and the socket and the new hip joint for the patient. So we're going to cut it in the operating room. We're going to ream it, open up the space. We're going to put a metal shell and a plastic. We're going to insert the stem. And everything that we do in the operating room has a special sizes. So every person has its own size. We have to measure, we have to find the right prosthesis for the patient, and we have to implant it. And ultimately, this is the picture of a hip replacement surgery. So this is a hip prosthesis at the end of the operation. This is an X-ray of a patient who had 2 hip replacement surgeries. So this is the right side. This is the left side. This is what you see on the X-ray when you get an X-ray for the patient. So this is the picture of the prosthesis that we implant. And sometimes what we need to do in the operating room to make sure that these stay in the place and doesn't move is that when we measure the components, it has to be extremely press-fitted. So that means it has to get into the shaft and get stuck. And as a result, the bone has these pores in it. When you look at the microscope in the bone has these small pores. And those prostheses also has a small pores. So eventually what happens is that these pores grow to each other and they intermingle. And the prosthesis and the bone becomes one. And that's how it gets stuck to the bone, so it becomes part of the body. So let me go ahead and talk about the operation, so that way I can show you guys how the surgery is done. I'm going to show a surgical clip of a total hip replacement operation. This is the patient laying on the side of their body. We are making an incision on the side of the hip joint. The incision is about 3 inches. We'll go inside the hip area where the hip socket is located. And we're basically removing the soft tissue so we can get the hip out of the socket. The whole operation is a very quick clip of surgery. It's about 2 minutes, so I'm not going to talk too much, but I will tell you the points so you can understand how the operation is done. So this is the head of the, this is that ball that we talk about. If you can see, the cartilage is all worn out, is all damaged. So we just took that ball out, and this is the socket. So this is the femur bone, the thigh bone, and we have to measure it and open up that canal so we can size it with a special prosthetics size femur. And we open the shaft, and we open the canal, and we size it. Each one of these has different size 1, 2, 3, 4, 5, 6, 7. As we go higher and higher, that means the patient needs a bigger prosthesis. And this is the socket inside the acetabulum. As I told you, the reamer, this is a special instrumentation that we use to get rid of the bad cartilage, to remove the bad stuff. And we open up so we can have a good bone. And when you have a good bone, then we start getting measurements to see what diameter the socket is so we can put the proper prosthesis in there. And this is the prosthesis that we are putting in, that shell that I told you that goes into the pelvis. So we press fit it inside, and it goes into the socket area and it gets stuck to the bone. And now we're going to find the right plastic that fits in here, because there's a special plastic that goes in here. And this is that plastic that's going to cover up, and that becomes the new hip joint. And once that's in place, we're going to put the, that shaft inside the thigh bone. This is the shaft that I told you. It goes into the thigh bone area. And that gets inserted inside and is press fitted.
In real time, how long is the whole surgery?
The operation takes about 1 hour.
Oh, okay. Well, you do it in 30 minutes.
I do it about 40 minutes, but the average time of this surgery is about 3 hours. This is the average time of the operation is about 3 hours. But the way we do it in the operating room, you know, the way the technique is, we do it in about 45 minutes to about an hour. Now this is that ball that I explained to you, and now we're going to put the hip back in, and that becomes the new hip joint. And this is a hip replacement operation, and now we're going to start suturing it. Now, the operation, you know, it has a lot of technicality in it. It's not as easy as I make it sound, because it has. We have to be careful the way the things are inserted to make sure that the patient doesn't get any dislocation, and making sure that the prosthesis works properly after the surgery. And after the surgery, we also have to make sure that the patient doesn't get any infection, doesn't get any blood clots. They have to get a lot of physical therapy so they can get their legs stronger. We also have to make sure that during the surgery, when we do this operation, one leg is not 1 inch taller than the other leg. We have to make sure that the leg length is equal. We do special measurements in the operating room. There's a lot of things that we have to do during the surgery to make sure things are getting done. Otherwise, the patient is going to walk like this after the operation, and that is not going to be a good thing. Yes?
Do you do both hip replacements at the same time?
We can, but we don't recommend doing both hips at the same time. We do one hip at a time. So let's move on to the knee replacement and what the knee replacement entails quickly, so we can cover both surgeries. Okay, so what is a knee replacement? A knee replacement, pretty much it has the same theory to it, and this is the knee joint. This is the thigh bone, this is the shin bone, this is the joint. So during a knee replacement operation, when nothing else really works, we have to go and shave off this end of the bone on the thigh bone, put a special prosthesis, shave off the shin bone, put a special prosthesis, special plastic in the middle. This is the kneecap. we also have to resurface the kneecap, put a special plastic on the side of the kneecap, and that way the bones will not be grinding with each other. And pretty much this is the picture of it. We cut the top of the shin bone because it's no good. We put a special implant on the top. This is the kneecap. We do the same thing. And this is the x-ray of a patient with a knee replacement surgery from the side view. If you're looking at it this way, this is the thigh bone, this is the kneecap, this is the shin bone. Now, knee replacement and knee arthritis comes to the patient in different way, and they manifest themselves in a different way. This is the normal knee. The normal human anatomy is lined up the way it is. When they get arthritis, patients become bow-legged. That is when the arthritis sets in the inner side of the knee joint and they start walking with the bow legs. Some patients come to the office when the outer side of the knee joint is worn out, and they come to us as a knocked knee. So you can get a knocked knee with a severe arthritis, you can get a bow-legged patient with a severe arthritis. They can come in different ways. This is the picture of the prosthesis that we implant for the knee replacement surgery. This is a picture of a knee with the worn out arthritis. The cartilage is all worn out. You can see all these raggedy area where the bone is exposed. And nowadays we do this operation instead of a 12-inch incision with a 3 to 4-inch incision, and the patient goes home in a couple of days. Now, I'm going to show you a special knee replacement surgery clip so you can also get an idea. This is a patient's knee in the front of the knee joint. We make an incision in the front and we make a dissection so we can go inside the knee joint so we can find those bones. There are ligaments around the knee joints that we have to release, so we make an incision, open up that ligament, so that way we can get to the bones. We put some special retractors in place, and that way you can see the knee joint. We have special instrumentations that we have to put in front of the bone. We cut the bone in a proper size. Every patient has a different size. We have to size it to make sure that we give the patient the right size prosthesis. And you know, we are human carpenters, so we use a lot of saws and a lot of nails and everything. So we have a special block that we size the bone, then we start cutting the bad areas. And as we do both sides, we have to do the femur side, and now we have to do the shin bone area. And we are also measuring the shin bone. We are cutting the bad parts of that shin bone. That way we get rid of the arthritis. We remove that part. This is the sizing plate. So we size that area because we have to pick a right size for the shin bone area as well. We prepare the bone for implantation. And the way that knee replacement surgery works is that after we cut everything, we have to cement or glue the prosthesis into the bone, because otherwise it's not going to stay. So we have a special human cement that we mix up, and that blue stuff is the glue. We put it in, we put that special plastic in the tibia insert and the tibia tray. And we also put that special metal on the top of the femur bone where we prepared, and we clean up all the extra cement from the area, and that becomes pretty much the new knee joint of the patient. So now you can see in the operating room, we test the knee, make sure that it's bending all the way, and we are extending it all the way, and it's about a 4-inch incision. The whole operation, we can do this in the operating room in about 45 minutes to an hour. Average time of this surgery is about 3 hours, but the way we do it, we can do it in about 1 hour. The ligaments, the ones that are not needed, we remove it. The ones that we made the incision, we repair it back with sutures, and we close the skin. Okay, so pretty much after the surgery, the patient stays in the hospital about 2 to 3 days. They get physical therapy. The physical therapist gets them up the next day. They start walking. After a couple of days, when they feel comfortable, they go home, and they have to do physical therapy for about 6 weeks as outpatients so they can get the muscles back to normal range of motion and strength and all that. Now, because of the time, I'm not going to go into shoulder surgeries and other operations that we do, so I'll just talk about the hip and the knee for now. Is there any questions?
Yeah.
Yes, sir.
Do you think the steroid shot in the knee is harmful?
If you do steroid injections 3 to 4 times a year, it is not harmful. It is a local anti-inflammatory. It helps to reduce the inflammation and the arthritis pain, and it allows you to do your activity of daily living without any problems.
Cortisone. Right?
Cortisone shot. Yes, sir.
My question is, how long is the replacement good for? The rest of your life, or do you have to do it again?
Very good question. The joint replacement operation, average longevity lasts about 15 years to 20 years. If you take care of it, you don't go jogging on it, it can last you around 20 years. But if you go jump and jog on it, it probably lasts you less than 10 years. So you have to be careful the activities that you choose. You can walk, you can swim, you can do bicycling, all that is okay. But if you go play basketball and go do a 5-mile jog every day, that thing is going to wear off.
So impact sports.
Yes, the high impact aerobics is,
Sport with high impact.
yeah, is not a good idea. Yeah, yes.
So you stated that glucosamine and chondroitin sulfate and vitamin E and cod liver are all things that can help prevent or
To reduce the inflammation, and it allows to lubricate the knee joint.
So then that would kind of postpone needing the surgery.
Yes,
correct?
yes.
But what age would you recommend if somebody needs a surgery? Is there an age that you recover quicker? Like, is there an age that you prefer to do it as opposed to waiting until somebody gets older?
Very good question. The average age for joint replacement operation is around age 60 to 65. Okay. However, we've done this operation on people as young as 40 years old. I've done this operation on people as old as 85 years old. At the younger population, when they're younger people, it becomes a question of quality of life. If somebody has severe arthritis and they're in agony and a lot of pain and they cannot do the things that they want to do and they're suffering, then we do this operation. In the same token, if somebody is 85 years old but they're very functional, like a 60-year-old, and they are suffering, we do this operation. So it has a lot to do with the patient, it has to do with the patient activity, and the needs that they have in their lifetime. Yeah.
Sorry, about the ligament, you said you're going to, how long is going to last that? What's going to be forever?
Which one?
The ligament.
Well, the ligaments that we remove during the surgery are the ligaments that you're not going to need after joint replacement. So only the ones. The ones that we remove, you're not going to need them anymore. But the ones that stays, we're going to repair them and sew it, and they're good forever.
That's good forever.
It's good forever, yes.
Would you talk briefly about neck arthritis?
Sure. You know, you have cervical spine, that is your neck area. You have 7 bones in your neck. You have about 5 bones in your lower back, and you have about 12 bones in your middle back. So it's called cervical, thoracic, and lumbar. Between each bone, you have a cushion that is called the disc. The disc has many components to it, but eventually with time, what happens is that the disc becomes worn out. You get degenerative disc disease. You also get arthritis set in those bones that we just talked about. So, and those bones are connected with each other with bones. So once you get arthritis set in, you're going to get facet joint arthritis. You're going to get shrinking of the tunnels where your spine nerves pass through it. Because of the shrinkage of the space, they put pressure around the nerves, and then you start getting nerve pain, pain coming down to your arms, pain coming down to your legs, numbness, tingling, and so on and so on. So essentially what happens when you get arthritis of those kind of areas, then you have to treat them with anti-inflammatories we can do injections like cortisone shots. And if none of those work or physical therapy doesn't work, then ultimately, then we have to talk about surgery, like a cervical spine, decompression and fusion and stuff like that.
Have you heard about acupuncture being effective for inflammation on the knee, for example?
Acupuncture is an old Chinese medicine. What it does is that it interferes with the nerve pathway. So what it does is that there are certain needles that they put in the pathway, so the nervous system, they trick it. So it essentially doesn't send the pain to your brain, so it signals as a pain. So it can help temporarily, but it doesn't fix the problem. Okay? Okay, so if nobody has any other questions, I'm going to give the podium back to Pam. Thank you very much for your attention.
Amazing. It was amazing, amazing. We truly enjoy listening. Okay, let me